I'd like to keep your hematocrit over 30. Okay, so very important you recognize that. All right, real life, it's art. Based on how the patient's doing, you can modify. But for the exam, we got to use these triggers. Okay? Correct, exactly. So for you and me and everybody else, we want to keep it over 24. But people with heart disease, we want to keep it over 30. Okay? Got it? So transfuse at 24, keep it over 24. Otherwise, cardiac heart disease, you want to keep it over 30. Excellent. But again, I don't care. If the patient's hematocrit is 31 and they're still having angina, I'm going to treat the angina and I'll probably transfuse you. Because if they're having anemia and it's giving them chest pain, I got to treat the anemia. I don't want them to have an MI. Okay? Good. Medicine's an art. Isn't it great? So much fun. All right, now let's go to the different types. We're going to start with the microcytic ones first. When I say microcytic, you say iron studies. Microcytic, iron studies. Microcytic, iron studies. Microcytic, we do iron studies. And this is the most common anemia on earth. We got to know iron deficiency. You're going to see this. It's the most common anemia. All right, now this is a problem with production of hemoglobin. Without iron, I can't make heme. So I'm not going to make a lot of red cells. So my MCV is going to be really small. It's going to be very small because a red cell is a bag of hemoglobin. If I can't make hemoglobin, I'm going to have very small cells. And they're very pale. Very pale. We call that hypochromic. All right, now here's a red cell. What percentage of the red cell should be pale because it's a biconcave disc? What percentage? Well, if you go from here to here, that's the diameter, 1/3 should be pale. See that? About 1/3 of the diameter should be pale. That's normocytic. So when I look at these cells here, what do you notice right away? The paleness is more than 1/3. See that? More than 1/3. Look at this one. It's like no hemoglobin in this dude. It's like all pale. So this is called a hypochromic cell. Not much pallor. So that thing doesn't have much hemoglobin. Now for size, you don't use the smear. For size, you look at the MCV. So MCV less than 80, very pale cells, microcytic hypochromic. Okay? Yeah, they don't have any iron. Can't make hemoglobin out of iron. All right, now why is there no iron? Well, in America, the #1 cause is blood loss, chronic blood loss. So you got to look at the GI tract. In a reproductive age woman, you look for menstrual flows, and they could also lose it in the urine as well. Okay? All right, now let's play the odds. Ready? Let's play the game. You're on step 2, and I say it's a 2-year-old with iron deficiency anemia. Where's the blood loss? Where's the blood loss? Oh, Avni, excellent. It's going to be GI. It's going to be a Meckles. Maggie, Karen, Nirja, excellent. Minchu, excellent. Bleeding Meckles diverticulum. A 1 or 2-year-old with iron deficiency, the answer is do a Meckles scan immediately. Do a Meckles scan. Look for Meckles diverticulum. All right, let's change it. It's a guy, our age. It's a guy, they're 20, well, your age, 22, 22-year-old medical student, 23-year-old medical student, 24. Where's the blood loss on a guy? The 30-year-old? Okay, that's good, it works. Could be hemorrhoids, but what else? What's more likely? Hemorrhoids possible. Inflammatory bowel disease possible. But where in the GI? Be specific. Tyler, you guys are great. Yeah, you got to think about a peptic ulcer. It's stressful in our age group. We got to take step 2 exams. Peptic ulcer disease, so they need an upper endoscopy. Upper endoscopy. So you see iron deficiency in our age group, upper endoscopy. Now, if they're a woman, it could be peptic ulcer or it could be menses. Menses as well. All right, finally. I tell you there's iron deficiency and they're over age 50. Where's the blood loss over age 50? It's GI. Where is it? The colon. Diverticulosis, colon cancer, There's something in the colon. So the next step would be what? What's the next step? Next step would be? What do you do next? Yeah, you're doing a colonoscopy, baby. Colonoscopy. So that's the rule. Over 50 with iron deficiency, you're getting scoped. No doubt about it. Very important. Okay, good. See, this is what they want on an exam. They want to know what's the next step. What do you do first? What do you do first? Iron deficiency in different ages, there's different things to look for. Excellent. All right, now who needs more iron because they're growing? Pregnant women. So pregnant women could easily get deficiency because the little dude, the little alien, is taking all your iron. So pregnant women need to eat. They need to eat a good varied diet. All right, malabsorption. Malabsorption could be a problem. You need acid to absorb iron. You need acid. So if there's somebody had a gastrectomy, something with a proton pump inhibitor they've been on for a long time, if you lost your acid, you have poor absorption. Now, how much iron do people need? Men need about 1 milligram per day. Women need 2 to 3. Well, obviously, when they're in the reproductive age because of the menstrual period. Okay, good. That's their daily requirements. Now, specific symptoms, you get the same symptoms as all anemias, but there are some clues. Listen closely. Not diagnostic. Not diagnostic. But these are good clues. When you have iron deficiency, the nails tend to be very brittle. But again, not diagnostic. You can get spooning of your fingernails. They call that koilonychia, spooning of the fingernails. You often get glossitis and pica. You start eating dirt, ice chips, eat things that aren't food, pica. All right, so again, these are good clues in the vignette, but I'm not going to diagnose you with just this. You got to give me more than that, right? All right, so we got to get the iron panel. This is diagnostic. Okay, you need the iron panel. So you tell me pica, great. Next step is still iron panel. Iron panel's next. Now, do you guys remember your iron panel? They love these because it's up arrow, down arrow questions, and students get diarrhea, right? Yeah, right? So very important here. Okay. Oh, Mamatha. I hope I'm saying your name right. Mamatha. There is a physiologic anemia of pregnancy, which is dilutional. But in addition to the physiologic anemia, they can, if they don't eat enough, the baby will take their iron. All prenatal vitamins have folate and iron as a minimum, because when you're growing a baby, they're going to take all your iron. So you can get it for both reasons. Physiologic, every pregnant woman has some physiologic anemia because of the blood volume. But in addition, they can develop iron deficiency if they're not eating a good diet, okay? Hopefully they're eating plenty, right? Gentlemen, get out of bed and go get them what they want. If they're hungry for something, go get it. It's the least you can do, right? Go get them what they want. Let them eat as much as they want. All right, now, iron panel. Very important you recognize this. So here's my rule. Whenever they give me an iron panel, I always start with the storage first. What's the storage called? Ferritin. Start with the storage first. Now watch this. You ready? 1 second diagnosis. Ferritin's low. Storage is low? If your storage is low, that's the definition of a deficiency. Low storage. Diagnostic. You're done. You got the answer. You're done. That is your most sensitive test. Look at that first. So if I can only pick one part, start with the storage. If the storage is low, boom, you're done. You're done. You got the answer. Storage is low, you're deficient. Now, we need to know all the arrows, though. All right, if storage is low, storage is in equilibrium with the serum. So if the storage is low, the serum should be low as well. That makes sense. So always start with this one first. If this is low, look at the next one, the serum. That should be low as well. All right, now this is the one they like to ask, TIBC, because students will get it wrong. TIBC, total iron binding capacity of the blood. What's in the blood that binds iron? Transferrin. This is equal to the transferrin level. Transferrin level. That's what it is. TIBC is the transferrin level. That's what transports iron. That's what binds it. Now, who makes transferrin? Your liver does. So if you want to get this right, pretend you're the liver. You're the liver. Whenever you're deficient, liver, would you like to bind more iron? You'd like to get some more, right? Well, if I'm deficient, I want to bind more. So the liver's going to make so much binding protein to try to get more, make more binding protein. So this is going to go up. This is called negative feedback. Negative feedback. Whatever the storage is, this should be the opposite. If I've got low stores, I want to bind more. I need more. So transferring goes up. On the other hand, if I had high iron, I don't want to bind anymore. TABZ, the transferring will go down. They're opposites of one another. Okay? So pretend you're the liver and you'll never miss it. Now, RDW goes up. Why? Why does the distribution of sizes change? Why is there anisocytosis? Well, remember, when you started out, you were normal. So you were making nice, beautiful, normal size red cells. Then you started to get a little bit deficient. So you started making a little bit smaller cells. Then you got more deficient, and you made even smaller cells. And then you got super deficient, and you were making tiny cells, right? Now, how long do red cells live? How long does red cells live? 3 to 4 months, 120 days. So right now in your blood, you've got some really old cells that are still normal size. Those are the old ones when you were normal. Then you got some that are a little bit younger, that were a little smaller. Then you got some that were fresher, and then the freshest ones are tiny. So you have all these different sizes because as you get more deficient, you're making smaller cells. So that's why the RDW is sky high. All different size cells. Make sense? Yeah, interesting. And finally, what's the reticulocyte count going to be? Well, listen, if I don't have iron, how many cells am I going to make without iron? Not much. Without iron, I can't make heme, can't make red cells. So retic count's low. Remember, retic count's usually high with hemorrhage and hemolysis. Good. All right, now here's an important caveat. I always look at ferritin first. If ferritin is low, the answer is iron deficiency. You're done. You got your diagnosis. Most sensitive test. Here's the problem. Ferritin is an acute phase reactant. So if you got some inflammation or malignancy going on, this is often elevated because of the inflammation. It can be falsely elevated. Okay? So if this comes back elevated, we got to look at the rest of the panel. Look at the rest of the panel to make the diagnosis. Okay? Because it could be falsely elevated. Okay? And if you can't figure it out, then you do the bone marrow. If you can't figure it out because the ferritin is increased, it doesn't make sense, then you do the bone marrow. And what stain should I do? Can anybody remember the stain that I need to do? The stain? Remember that stain? Yeah, the Prussian blue stain. This is going to be the most accurate diagnostic test. We don't usually do it. It's pretty rare to need to do it, but it's the most accurate. So let's repeat. What's the first test I should do here? Ferritin. Get the ferritin, the iron panel. But it is sensitive. It's not specific though. Okay, so it's very sensitive, but because it's an acute phase reaction, it's not 100%. Okay, so again, always start with ferritin. This is your first test, the iron panel. Always do this first, and it's very sensitive. Now, when I ask for specific, well, the most specific test is your bone marrow Prussian blue. Prussian blue, because that's going to show you your stores. It's going to show you the real, you got to look at them and see what they are. Make sense? Okay, if there's inflammation or cancer, ferritin may be high, but the serum iron is usually still low. The rest of the panel is still usually intact. It's usually intact. But again, if it's confusing, then you do the bone marrow. Okay? But rarely done. Even on USMLE exams, rarely done. What they will ask is, what is the most specific test for iron deficiency? Most specific, Prussian blue of the bone marrow. Most specific. Good job. All right, now how are we going to treat this? Remember, diagnosis, treatment. Diagnosis, treatment. That's all step 2. Diagnosis and treatment. So how are we going to treat it? You're going to give iron. If you're deficient, you give iron. You give oral ferrous sulfate. Okay, good. Now, when would I give it parenterally with IV? When would I do that? IV. Well, I do it if I couldn't absorb it. Maybe I had a intestinal resection, maybe I have no acid, or maybe I need a lot, and I just can't absorb enough. But mostly we do it because of intolerance to therapy. So please tell me, what would be intolerance? What would be intolerance? What's the intolerance? What do you mean intolerance? Ah, yes, constipation. Lovely, wonderful constipation. When you give somebody oral ferrous sulfate, they usually stop taking it because of the constipation and GI upset. That's usually they can't do it, they stop it. So again, if you can't get enough iron on board, either because of malabsorption or intolerance, then you're going to do it parenterally. But again, do you want to do? No, we don't want to do. We want to do oral. Oral's always better. Okay, but parenteral if you have to. All right, now one more thing. You might want to, if they have low acid, you might want to add what? What might you want to add when you give oral? If they may have some like proton pump inhibitors on board, you might want to give some ascorbic acid. Let's give some vitamin C because that will help with the absorption. So ascorbic acid, vitamin C with it. Yeah, you do that if they had low iron. Low iron plus low acid. So somebody on a proton pump inhibitor. Okay, good. Excellent. Now, oh, by the way, board question. What is the most effective, efficient way to give iron? Well, oral iron's not absorbed that well. Parenteral's a little better. Parenteral's better, but even better, blood transfusion. Mariana, excellent. Blood transfusions are the most effective way to give iron. Listen closely. 1 unit of blood, 1 unit, has almost a year's worth of iron in it. 1 unit of blood has almost a year's worth of iron. So that's a pretty effective way. But in real life, we don't do it. We don't do it. We don't correct iron deficiency by transfusing you. We just don't do it. But on the exam's artificial. If they ask what is the most efficient way of giving iron to a patient, a transfusion would be the answer. I know, it's like, what? Yeah, a transfusion. Yeah, because 1 unit of blood gives you almost a year's worth of iron. Pretty amazing stuff. All right, so again, oral is preferred. You only do IV if they malabsorb or they intolerant, and then blood transfusions are never done really. We never do blood transfusions for giving iron. We give blood transfusions to give you blood for hematocrit and hemoglobin, but not for iron. Okay, good. These exam writers come up with some good questions. All right, now let's change gears and talk about anemia of chronic disease. The problem here is I got the iron. I got it. I can't use it. So this is called an iron reutilization problem. I got the iron, I can't use it because of the inflammation. And the reason for that is it gets trapped. It gets trapped because whenever there's inflammation, you'll have an increase in hepcidin. Hepcidin. So let me repeat. Whenever there's inflammation, the liver releases hepcidin. Hepcidin goes up. Now, what will hepcidin release from the liver do? Well, it blocks the iron ports. It blocks the ports. So number one, the ports in the GI tract are blocked, so you can't absorb iron. So GI absorption will decrease. You won't absorb it into your blood because it blocks the iron ports in the GI tract. Number two, it's going to block the macrophage release. Remember, you store your iron in the reticuloendothelial cells. You store iron in your macrophages of your reticuloendothelial cells. What it does is it blocks the ports. So the macrophages can't release the iron. They can't release it because the ports are blocked. So the macrophage has the iron. It just can't release it because the port is blocked. The port's blocked. Can't release it. So let me repeat. Do I have iron? Yeah. I just can't use it. I can't release it. So we call this an iron reutilization problem. They got the iron, they just can't use it, they can't release it. So look, if I can't release the iron into the blood, then my marrow won't get any iron and I can't make a cell. I'm going to get anemia because I'm not releasing it. Make sense? And over time, it's going to build up and build up. Every time a red cell dies, the macrophage will eat it and it will hoard the iron. It doesn't release it. So this is going to start out as a normocytic anemia. It starts out normal size. But then the iron's going to accumulate and you're going to get more and more microcytic over time. So it starts out normocytic. If you catch it early, catch it late, it'll be a microcytic. Okay? Okay, good. Excellent. All right, now let's talk about etiology. For etiology here, the anemia of chronic disease usually affects any patient with a chronic inflammatory disease. So any chronic inflammatory condition, rheumatoid arthritis, lupus, any infectious disease like a smoldering TB, smoldering mastitis, any tumorous condition. You got metastatic cancer, you're going to get the anemia of chronic disease because the inflammation, the hepcidin goes up. All right, now let's do the panel. Ready? I got the iron. So if I look at the storage, what's the storage going to be? It's going to start out normal. I got it. And then since the macrophage never releases it, it accumulates and accumulates and accumulates, and eventually the storage will be high. Okay, so I got the iron. The problem is I can't release it. Storage should be in equilibrium with serum. They should be in equilibrium. So here's how you diagnose it in 1 second. I got the storage, but it's not going in the blood. I got it, I'm not releasing it. I got it, I'm not releasing it. Diagnostic. Boom, that's it right there. That's how you diagnose anemia of chronic disease. Okay, they got anemia. It's going to be microcytic in most cases. You're going to do the iron panel. You're going to see either a normal or high iron storage with a low serum iron. They're not releasing it. This is all due to the hepcidin. Hepcidin doesn't allow it to get released. So that's why you get the anemia. Now, you're the liver. You've got plenty of iron. Do you want to bind more? No, I got plenty of iron. So the TIBC will drop because you don't need iron. You need to use it. You're not using it. Okay, to me, it's like a pretty girl. It's like a pretty girl. Anemia of chronic disease is a pretty girl. She's got it. She ain't giving it up. She's got it. She ain't really. It's like a pretty girl. You got the iron. You're not using it. You need to use it, but they're not using it because of the inflammation. That's the problem. Okay? All right, now, reticulocytes. How many red cells are you going to make if you're not using your iron? Not many. Reticulocyte count's low. Can't make red cells if I can't get any iron. Now, symptoms will be the same as any anemia. And of course, you'll have the symptoms of whatever disease is causing it too. All right, now treatment. Duh. Treat the disease. If you stop the inflammation, then the hepcidin goes down to normal. The ports open up, the iron comes out, the anemia goes away. Treat the underlying disease. Now question, the wrong answer will be giving iron. Why won't iron work? Why won't it work? It's not an iron problem. If I give you iron, the macrophage will eat it and it won't release it. You're going to get hemochromatosis because the macrophage will just accumulate and won't release it. So that's the problem. Giving iron will only make things worse. It's not, they have iron. It's not an iron problem. Now, erythropoietin ain't going to work either. If you stimulate to make more red cells, they still can't make hemoglobin. Now, I would give erythropoietin if the chronic disease was renal disease, right? If your kidney doesn't work, you need EPO. Or if I gave chemo and I killed the bone marrow to help the bone marrow come back, I'd give EPO. Okay, but still, you got to treat the underlying disease. Treat the underlying disease. Okay, and again, if it's kidney disease, give them EPO and get them a transplant. Get them a new kidney. All right, now the next microcytic, we got 2 microcytics done, we've got a couple more to go. Next one is called sideroblastic anemia. Sidero means iron. Iron in your erythroblasts, in your normal blasts. So iron's accumulating in the blasts. Now, this is a microcytic anemia, and again, it's a problem with the synthesis of hemoglobin. All these microcytic ones are hemoglobin problems. All right, now it's characterized by trapping of iron in the mitochondria of the precursor cells, the nucleated red cells. See, in your bone marrow right now, in your bone marrow, you got these normoblasts. Normoblasts, they have a nucleus. Right now, if I did a bone marrow on you, they got a nice nucleus. The job of this normoblast is to synthesize iron, synthesize hemoglobin. That's its job, to fill up with hemoglobin. Make hemoglobin, make hemoglobin. Remember, a red cell is a bag of hemoglobin. So it's supposed to make hemoglobin. That's the job of your red cells. Okay? So these normoblasts are supposed to synthesize hemoglobin like crazy. Now, once they're full of hemoglobin, once they're packed, the nucleus will get removed, and now it's a baby red cell. What do we call a baby red cell? They're so cute. What's a baby red cell called? It's a reticulocyte. Oh, it's so cute. The baby reticulocyte. Okay, so it'll be a reticulocyte. Then it'll go into the blood, and after 1 to 2 days, it will mature into a red blood cell. This is where your blood comes from. It comes from your bone marrow normoblasts. Okay, now this is normal. What if somebody gets lead poisoning? Lead poisoning will give you a sideroblastic anemia because lead interferes with ferrochelatase. Just remember, the last step is to put the iron into the protoporphyrin ring, and you make heme. That's the last step. Put iron in with ferrochelatase. Lead poisoning interferes. So the iron accumulates in the mitochondria right next to the nucleus. It just accumulates and accumulates and accumulates. Iron just accumulates and accumulates. Now we're going to call this cell a ringed sideroblast because it's packed with iron. Ringed sideroblast. Ringed sideroblast. Ring of iron. Now make me proud. Make me proud to see a ring of iron. Nemo, it's the ring of iron. The ring of iron, Nemo. To see the ring of iron, Nemo. What stain do I need? What stain to see it? Prussian blue. So right away, you know the diagnostic test in this one to confirm it. Ultimately, I'll start with the iron panel, but I need to confirm it with the Prussian blue. I need to see a ring of iron. Listen, if you're going to tell me it's sideroblastic, I need to see a ring sideroblast. I need to see a ring around the nucleus, ring around the nucleus. That's a ring sideroblast diagnostic. So that's your most specific test. Bone marrow biopsy, because ring sideroblasts are not in blood. They're only in the bone marrow. So we're going to have to do a bone marrow biopsy with the Prussian blue. That's how we're going to confirm this diagnosis. That's your most accurate, specific diagnostic test. Bone marrow biopsy, Prussian blue test. That is going to show me the ring sideroblast. Diagnostic. Okay, got it? So I went right to the diagnosis here. Again, I said microcytic, so we'll do iron panel first, then we'll confirm it with the Prussian blue on the bone marrow. All right, now let's talk about what causes this. We talked about lead, but there's other causes too. You got hereditary forms where you have a defect in making the ring. If you can't make the protoporphyrin ring, you can't make hemoglobin. Iron's just going to sit there. It's never going to go into the heme. You can have a problem with B6. B6 is a cofactor for synthesizing hemoglobin. You can have acquired forms, drugs. Do you remember isoniazid? Oh, that's a favorite step 2 question. Patients on isoniazid, what happens? You get B6 deficiency. So they're at risk for sideroblastic anemia. Alcohol. Alcohol damages the mitochondria, so the iron accumulates. It's a mitochondrial poison. And of course, lead. Lead poisoning damages the enzymes like ferrochelatase. Okay, so these are the classic forms. Now, one more. You can get ring sideroblasts with myelodysplasia. This is a pre-leukemic disorder. Pre-leukemia, myelodysplasia. Okay, so you'll see refractory anemia with ring sideroblasts. That's a form of myelodysplasia. myelodysplasia, pre-neoplastic. So let's look at it again. B6 deficiency, like isoniazide, alcohol, oh, lead poisoning, they love lead poisoning, and dysplasia. So if I was going to memorize only two, I definitely want to know lead poisoning, and I probably want to know about isoniazide and B6. They kind of like that. Okay, now in real life, alcohol is a big problem with this, and then rarely you'll see myelodysplasia. Okay, so those are the ones I want to commit to memory. All right, now we'll always start, when I say microcytic, you say iron panel, microcytic, iron panel, microcytic, iron panel. Now, did you see all that iron? You saw that iron, right? Let me go back here. Take a look at all this iron sitting in here. See all that iron? See all the iron accumulation, iron, it's a ring sideroblast. So what do you think the storage is going to be? What's the ferritin going to be with all that iron sitting there, not being used? I think it's going to be high. I don't think I need to memorize this. Okay, so clearly the serum ferritin, the storage is going to be sky high. You saw it sitting there. Now, the storage should be in equilibrium with the blood. So if the storage is high, the blood should be high as well. Perfect. Perfect. You got high storage, goes in the blood. Perfect. Now, what is the TIBC going to be? Well, if you got lots of iron, do you want to bind more? You got too much, you don't want to, you got ringed sideroblasts. You don't need any more iron, so you stop binding it. TIBC will drop. Okay? By the way, this is the same arrows as hemochromatosis. It's the same arrows as hemochromatosis has. Same iron panel. It's just the levels are different. Hemochromatosis, the levels are so high, you're getting tissue injury. Okay? All right, now, to confirm this, because the symptoms of all anemia are the same, there's no specific things here. You got the iron panel looks like this. We'll confirm it now by doing the most specific test. And that was the Prussian blue stain of the bone marrow. Because you can't see ring sideroblasts in the blood. They're only in the marrow. That's where you make red cells. It's in the marrow. So get a bone marrow, do a Prussian blue, and you'll see ring sideroblasts. Now, I looked at this picture earlier, and I was like, geez, I can barely see them. Do you see any blue dots, like right there, some blue dots? Maybe this one's a little better. This one's pretty good. Blue dots around the nucleus, blue dots. Man, I wish the picture was a little closer. I'm a pathologist, and I'm kind of using my imagination. Do you see any blue in there? You're supposed to see blue dots around the nucleus. I just wish the picture was a little better. It's kind of hard to see. But if you go to Google and type in ring sideroblast, you'll see some nice ones. Blue dots around this nucleus. It's just kind of hard for me to see here. I think I'm using my imagination. Now listen closely. For only lead poisoning, only lead, what would I see in the blood? I will see basophilic stippling. Blue dots in the red cells. Basophilic stippling. But that's only seen with lead. Only with lead. Okay? So they all have ring sideroblasts, but only lead poisoning has basophilic stippling on the peripheral blood. So this is the peripheral blood smear. This one was the bone marrow. Bone marrow. Okay? Got it? All right. Now again, I'm sorry, the pictures, I got to get better pictures than this. But I think you can at least use your imagination. So blue dots around the nucleus of the bone marrow, little blue dots in on the Prussian blue, that's going to be a ring sideroblast. And then on a regular blood smear, if it's lead poisoning, you'll see blue dots in the red cells. That blue dot's called basophilic stippling, little blue dots. All right, now treatment. The treatment is if it's a drug-induced, stop the drug. Stop the INH. Stop the INH. Whatever drug it is, stop the drug. And then what vitamin do you think I should give? What vitamin would you be giving here? Should give what vitamin do you think? Yeah. I always give B6. Always give B6 because it may get better. Give B6. Okay? And of course, if it's lead poisoning, we'll treat the lead poisoning, right? How do you treat lead poisoning? I forgot. Can anybody tell me how you treat lead poisoning? Does anybody remember? Okay, you're going to use a chelator. Excellent. You get chelator. But ferrous is for iron. Ferrous is for iron, right? Ferrous is for iron, right? Yeah, we're going to use chelators for lead. So in children, we usually use Succimer. Succimer. Okay, for adults, we use the IV ones. We use EDTA and or dimercaprol. Okay, so these are the classic chelators for lead. Yeah, deferoxamine, that's really good for iron. So for iron overload, we can use deferoxamine. But for lead we like to use Succimer in children, and adults use EDTA and dimercaprol. Okay, so it's treat lead poisoning. So stop the drug if it's a drug. If it's lead poisoning, treat the lead poisoning. And then again, as I mentioned, let's give B6. Let's give B6 because some of them will respond to it. Give B6. So treat the cause and give B6. All right, now, if they get a lot of iron accumulation, remember I told you it's the same pattern as hemochromatosis? If they get iron, too much iron, we'll have to chelate the iron if they get iron overload. That's when we can use the iron chelators. Okay, so deferoxamine could be used there if there's iron overload. All right, now the last of the microcytic anemias is thalassemia. That's the last one, thalassemia. Now, this is not a problem with iron. This is a problem with the globin chains. So let's see how good you are. This is going to be a microcytic anemia. So what's the first test, doctor? Come on, I'm going to give you a break, but you got to tell me, what's the first test when I say microcytic? You say the iron studies, the iron panel. Excellent, 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 excellent. Yes, iron panel. What's it going to be in thalassemia, which isn't an iron problem? It's a globin problem. What's it going to be? It's going to be normal. So let's repeat that one more time. If it's a microcytic anemia, you get the iron panel. If the iron panel's normal, it's normal. It must be thalassemia. You start thinking thalassemia. So microcytic with a normal iron panel, start thinking thalassemia. Now to prove it, the test we're going to do here is hemoglobin electrophoresis. Hemoglobin electrophoresis, very useful here. Okay, so when the iron panel is normal in a microcytic disease, think about thal, and you want to do electrophoresis for these. Okay, all right, so we'll come back and we'll get these in a few minutes, but first we're going to take a break. I hope you guys are having fun with this. Blood should be easy. Blood's an algorithm. If you get your algorithm, you should never miss these questions. Okay, so let's take a well-deserved break. We'll come back in 10 minutes and we'll tackle thalassemia, and then we'll move to the hemolytic ones, which are much more fun. Okay, see you in a little bit.